So let's go through the Q&A.
So let me just ask you a question, Mark, first,
Sure.
just since you talked first. And I think it's a really interesting question, and Twitter has been buzzing about this question. So I thought it'd be really good to ask you. So we now have the Keynote 522 data that you covered nicely. And you have patients who have a PCR. And I think one question is, if you have a PCR, would you complete the year of pembrolizumab? That can be given every 6 weeks. So you could just give it 5 doses at 400 milligrams. It's in the package insert. Or what? And so that's one question. Second question is, what do you do if you don't have a PCR? So if you're wild type for BRCA, are you going to give pembro alone, pembro with CAPE, CAPE? If you have a BRCA mutation based on the Olympia data, are you going to give olaparib, pembro, or both?
Well, I mean, I usually like to choose one or the other and stick with it. I'm not one to mix trial data across trials without any, safety data or any other basis for making up regimens. So if you look at the data sets, I guess I'm probably most impressed by the magnitude of the treatment effect from the PARP inhibitor for BRCA mutant patients. I'd probably use that. Lacking any data of PARP inhibition plus checkpoint inhibition in the adjuvant setting, I don't think I would do that off study personally.
And what about if they have a wild type for BRCA?
Wild type BRCA triple negative, then and they have residual disease, no PCR. Right. So, well, then you're looking at the capecitabine because that platinum ECOG study failed to demonstrate superiority of platinum compared to capecitabine. So capecitabine would still carry the day for the wild type. The question then is, in the wake of Keynote 522 and the recent FDA approval of that regimen, I think I probably would use the pembro regimen. And whether or not you can layer in CAPE with that, I don't know. There is no adjuvant data to support that yet. So I probably wouldn't. I'd probably just do pembro, neoadjuvant and adjuvant, according to the prescribing information. I don't think I would stop short if I achieved a PCR either, because even though the Gepar Nuevo data did that and it looked pretty good, still I'm data driven. I like to follow the protocols as they were done and not venture too far off the reservation from what the prescribing information recommends. So I'd probably do pembro. And then I think there is safety data with the CAPE immune checkpoint inhibition combinations. So I guess if you had a locally advanced case that was really severe and high risk, you could consider, trying that combination. But, there isn't any, level 1 evidence from randomized trials showing that approach will be fruitful. So it's a little bit of a stretch.
Yeah, it's interesting. So, I'm a much more of I think you're more of a splitter. I'm more of a lumper. I always attribute it to having done bone marrow transplants for 10 years, but where you give everything, but I agree. I think the magnitude of benefit with the PARP inhibitor is really big. And so it would be, I would use olaparib in that setting. And I think, there's only 170 odd patients in Gepar Nuevo. And so I think that, it's small in terms of the weight of the data. But I think that it still would be reasonable. You gave the pembro preoperatively, and then you would use olaparib post-op. But capecitabine, it has benefit in people from Japan and Korea, but the benefit in the ECOG trial, still 55% of patients had recurrence in those 3 years. So I would be more motivated to give the CAPE and continue the pembro. And we have safety data with that combination in the metastatic setting. So I don't think there's really any issue with doing it, relatively.
Yeah, I agree. It could be done. It's probably feasible. I'm just acknowledging that there's no data from randomized controlled trials yet in the adjuvant setting to support that combination.
I can't imagine there will be.
No, I can't either.
Yeah, but it took so long to do Olympia already, but such incredible results. And I think because of those results, another question that came up is whether there's benefit for using a PARP inhibitor. And if you have hormone receptor negative, HER2 positive disease and a BRCA1 mutation, would you, and they say less than 4 lymph nodes, but we really don't have any data for using a PARP inhibitor in HER2 positive disease. in this situation. So what would you ever consider that? Would you do something different than, for example, trastuzumab emtansine?
I probably would go with TDM1 for a non-PCR HER2 positive, even if they had a BRCA mutation, just because, the Olympia trial was not done in the context of HER2 positive disease. So I don't know how well it would apply to that situation. We have, lots of data on targeting HER2 in that circumstance, and that's been so highly successful. That's a very high bar to beat with a PARP inhibitor. So I think I would stick to the HER2 targeting strategy. It's a bona fide target, it's a driver. We have a vast experience and tens of thousands of patients worth of phase 3 data. So
and
yeah,
outside of BRCA mutation status, I mean, it seems to be effective in both settings. It's an interesting question. I have a patient who has a BRCA2 mutation, ER negative, HER2 positive, de novo metastatic disease presented during pregnancy. And had, she hasn't gotten a PARP inhibitor yet, which is kind of amazing. And she hasn't got platinum either. So it does give you an idea. This is now many years ago, and she had mets to liver and got Cleopatra-like regimen, started progressing in a year, got TDM1, progressed in a year, and then went on Destiny Breast 01 and got trastuzumab deruxtecan, of course, before we knew anything about having interstitial lung disease, but she's still on that now at 3 years, so longer than any other treatment that she's been on. So it is impressive. One other question, we want to make sure that we get everybody to the break in about 5 minutes, and we have, of course, can answer any questions that people want to submit now, as long as we have time. But a question that comes up a lot for patients is they got a CDK4/6 inhibitor in the first-line metastatic setting, and with an AI, say, and now they're progressing. They don't have a PIK3CA mutation, and maybe they have an ESR1 mutation or not. But what do you do then? I think the questions are: do you give everolimus with fulvestrant? Do you continue a CDK4/6 inhibitor? Give a different one. If you gave palbo or ribo, would you give a bema? Have you done that before? And what do you think about that idea?
No, I've never switched from one CDK4/6 inhibitor to another, in class at progression. I don't know of any strong scientific rationale why that would be effective. That said, there are clinical trials that are doing just that are underway now, as I understand it. So we'll get an answer to that eventually. But it just doesn't make any sense to me. I don't think these drugs are different enough in terms of their mechanism of action or metabolism, or active metabolites, et cetera, to be able to expect differences in outcome from switching from one to another. So I don't do that. What I do is fulvestrant-based treatment. Since the precog 0102 data is a positive randomized trial, I do tend to favor adding everolimus along with fulvestrant at the progression point these days. But if someone can't tolerate everolimus well, or if for some reason doesn't want to take it, I have no problem with single agent fulvestrant in the PIK3CA wild type patients. Also, it's a great choice, and I've had patients that can stay on that for a very long time indeed as well.
Yeah, I think that's really, I think, the only approach you can have. We just don't have the data. And hopefully we'll see data from the AKT inhibitors that are being studied across wild type and mutated PIK3CA, capivasertib and ipatasertib. But they do have some toxicities, just not quite as much as alpelisib, the alpha specific PI3 kinase inhibitor. But I've had a couple of patients who really wanted to stay on a CDK4/6 inhibitor. One switched to abemaciclib, and she's still on. The other one wanted to stay on palbo before there were any others. She was on, I think, Paloma 2. Both stayed on for a long time, so it's hard to know exactly. And that's why we really need the randomized data. In our last couple of minutes, there's a couple of questions here. Let's see if we can quickly do both of them. So in patients who have metastatic de novo hormone receptor positive disease, got fulvestrant and a CDK4/6 inhibitor, and then progress on tumor markers, but not radiographically. Do you change ever based on tumor markers? So I tell patients two things: symptoms and radiographs. Do you change based on tumor markers?
No, I tend not to follow unless they're difficult images to read for some reason. Sometimes bone only can be tricky, in which case maybe the markers would be a little bit helpful just to, distinguish
Yes.
between a flare response versus progression. But other than that, I typically won't act on markers alone. I want to see RECIST progression even in off-study clinical practice situations. That's my habit. And so you can, who knows how much longer time you might get mileage out of that regimen prior to RECIST progression. And that's a good thing. If it's well tolerated and that things are going smoothly, I wouldn't
Don't
mind them.
care about the markers.
I'm not
Yeah.
impressed. That's
And
right.
unless somebody's symptomatic, for example, bone-only disease, sometimes people develop bone pain and you just can't see it, but that's one reason to change. And then just this last one we were able to sneak in our last minute and a half or so is an 89-pound, 88-year-old woman got trastuzumab and pertuzumab for metastatic disease, but ended up in the ICU with severe diarrhea, kidney injury, hypotension, and refuses further pertuzumab. Also is BRCA1 positive. Would you give trastuzumab and a PARP inhibitor?
I'd probably do one or the other. I'm not sure that I would do both in an 89-pound, 88-year-old in the ICU. I probably wouldn't. That sounds pretty risky. I'd probably stick to HER2 targeted therapy. And it doesn't say she progressed. So
no, she just can't tolerate. I agree. I would give
ER positive. I would use an anti-estrogen and trastuzumab.
Yeah, I would too. And I think you could give an AI, and if she has ER positive disease, you give an AI and trastuzumab. If she has ER negative disease, you can give trastuzumab, or for example, low dose TDM1 even, if it's metastatic disease. And I think then you can give the olaparib, talazoparib later. You don't have to give it now. And I do think it's a little bit harder because of the anemia that you see. So
that's correct.
I think it might be better to wait on that.
In this kind of a situation.
Yeah.
The myelosuppression and anemia, I would stick to the HER2 targeted therapy.
Yeah.
In terms of therapeutic index, that's got to be the winner.
It's been really fun to talk to you, and I love hearing your talk. And we appreciate, of course, the ability to participate in this ASCO update. For the audience, thank you guys for participating and sending in questions. And please visit the exhibits now and talk to people there. I think it's fun areas to learn and interact. And then the session will start again at 2:35 Pacific time now in 14 minutes. So have a great rest of your afternoon.